All right, so anyway, so we're talking about cancer. What is cancer? Good to describe it. Abnormal cell growth. What's abnormal about it? Uncontrolled, yes. We're having unchecked cellular growth that eventually will take over the patient, right? So what are some normal ways that cells do not grow out of control? Like what are some ways that we can control that sort of thing? Cell death, yeah. So we have like programmed cell death. Anyone know the term for that? Apoptosis, yep. So there's apoptosis, which is really important. A lot of our cancer cells lose that, so they don't get that signal to, hey, we should probably go ahead and kill ourselves off at this point. You also have a lot of issues where maybe growth factors are being produced in too high an amount. If you think about like breast cancer, what's a really important hormone for causing breast cancer? Estrogen. That's a growth factor for breast tissue. So that's one of the things you can run into with that. So growth factors are going to be usually in the kind of higher amounts than normal. You're going to find that you have these cyclin-dependent kinases. This will be important for a class of drugs we'll talk about a little bit later. But these are also going to be important for kind of signaling cells to grow when they shouldn't be or grow inappropriately. We'll have these p53 genes. Those are the ones that trigger off apoptosis, and those are usually going to be depressed as far as their expression goes. And then you also lose contact inhibition. You guys know what that is? This is where the cells are kind of like they're growing right next to each other. Once they kind of get the signal that, hey, we're kind of crowded in here, they kind of stop growing. But cancer cells don't necessarily do that, so they kind of continue to grow regardless. That's how you get those very large tumors. That's how you get cells that start to break off, and then when they start to form little colonies elsewhere, what do you call those? Metastases at that point, right? So again, so you kind of can see some of the problems with this. Our goal is to prevent these cells from continuing to grow. There's lots of ways we're going to deal with that, whether it be surgery, whether it be radiation, or as we'll talk about here, primarily the drugs. So basically, we're going to talk just about the very basics. You probably have covered this already, but I'll just kind of get it for our purposes, how we talk about these. Basically, you have to kill every single cancer cell. If you don't kill off all those cells and you have one that has that alteration that continues to allow it to grow, guess what? It's going to continue cloning itself, and you're going to have the cancer come back. How easy is it to get rid of every single one of those cancer cells? Very difficult. It's very near impossible to get rid of every single one of those cells. That's why we have recurrence of cancer that happens with some frequency depending on the type you're dealing with. You're going to find that different tumors have different growth patterns that will change how they grow. And so you're going to find that when tumors are very, very small, they're able to disseminate, or they're able to grow very rapidly. Usually there's going to be a point where they're going to hit kind of a plateau where they can't continue growing. A lot of that has to do with nutrients. A lot of it has to do with blood supply, things like that. So we'll talk about those kind of tumors in a little bit. But you can have very well-differentiated versus non-differentiated types of cells where they very much resemble kind of the original tissue they come from. Very not well-differentiated means they look very, very different, right? They have enough of those kind of mutations that make them not really act the same as these kind of original cells did. Some will be very slow-growing versus very fast-growing. Which one do you think are more dangerous to your patient? Very fast growing, right? Because again, they're taking up all the nutrients that your patient's regular cells need as well. And so you can see how that can be a big deal. So if you think about things like colon cancer, prostate cancers tend to be a little bit slower growing than versus something like a leukemia. That kind of makes sense because again, if you had to imagine what type of cells you're producing at a higher rate, you would expect white blood cells, right? So again, if you're constantly producing white blood cells, now they have this alteration where they're kind of growing uncontrollably. You can see how that can be kind of a problem. Localized versus disseminated. This will be important as far as, are the cells really well localized? If they are, they're localized, there's just one spot, what could I do with that? Cut it right out, right? Versus if it's very well disseminated, I can't really get away with that. So imagine like, a single tumor, you can cut that out potentially. Surgery is an option. Leukemias, you can't really do that. They're all disseminated throughout the bloodstream, lymphatic system. Like you can't do that. That's where we need more systemic therapy. That's where a lot of our drugs are going to be coming into play here, right? And then you're going to look at the heterogeneity of the tumor. That just basically means like how many different types of cell types are going to be involved here. That can be important because different cells respond differently to different types of chemotherapy. And so that can be important when trying to figure out kind of what's going on with your patient. So there's this term, I don't know if you guys have heard this, Gompertzian cell growth. Ever heard that term? It's kind of a fancy term you can use to impress your friends. Basically, it just means that every tumor takes about a constant amount of time to double its size, right? Because again, that mitosis phase, where they're doubling, it really doesn't really change a lot, right? So again, it's the same process no matter how big the tumor is. But as that tumor gets bigger and bigger and bigger, it will start to outstrip its nutrient supply, and that's where we're going to run into this kind of plateau. And I'll show you a curve of that in just a second here. But you'll have very rapid initial growth when the cell count is low, and then as it gets bigger and bigger and bigger, it will start to slow down to a great degree. Here's an example of kind of cell growth and how this can occur here. When you have the tumor that's actively replicating, eventually you're going to have a plateau where it's going to outrun the cell growth or that nutrient supply, and it's going to basically kind of plateau out. It can't really continue to grow kind of ad infinitum as it had been. Now, if you notice here, we're talking about different types of therapies here. So imagine, is it always possible to catch cancer the second a person has a cancerous cell? No, you usually have to wait a period of time, right? You usually have to wait for the cancer to get well progressive enough to where the patient's either having symptoms, or if you're doing routine screenings, you can kind of screen for these things early on. That's why we screen for very common things like breast cancer and prostate cancer with different diagnostics. But anywho, what you're going to find is that even if you were to kill, say, 3 log units or 99.9% of these cancer cells, so imagine I did something like surgery where I had the surgical mark here, where I'd knock down all the cell growth here. What happens after that? What happens to the cells that are left over? They're going to start to replicate again. And so you're going to notice that there's going to be this cyclic kind of treatment modality that we're going to use for these these patients who have cancer. Basically, you're going to give them either a round of chemotherapy, or you're going to give them a surgery, or give them radiation. That will knock down that cell count. Those cells are going to start to regrow, but then you're going to have to give them another cycle and another cycle. So that's why you see a lot of these kind of multimodalities things where you'll have, say, a patient gets radiation, try to shrink down a tumor size, and then they'll get chemotherapy, several rounds of that, in order to try to make sure that we're trying to kill as many of those cells as possible. Because again, you leave one behind, they're all going to come back at some point, right? Presumably. So, and just looking at the number of cells here, even if you only have, say a 1 kilogram tumor, you think that sounds pretty big, right? Kilograms, how many pounds? Yeah, it's pretty big, right? So that's 10 to the 12th cells, but even if you only let this 1 millimeter little tiny 10 to the 6th cell, that's still 1 million cells that are left behind that can replicate. So that's why it's so important to make sure we really try to knock this down, and we'll see how we do this with our chemo drugs. Okay. So again, treatment should be involving removal of the tumor as a first step. So surgery is really good for kind of well-localized, well-differentiated tumors. Radiation therapy are going to be better for tumors that are localized, because again, if you irradiate the entire patient, what happens to them? Is there any of these therapies really benign for the patient? No, right? Surgery is probably the least offensive, because you can just go in and cut something out, and it's just like a typical surgery. Radiation, though, if I irradiate cancer cells, I kill them off. If I irradiate healthy cells, they also die off too, right? Same thing for chemotherapy. When I'm giving these drugs, and that's why I mentioned I don't like to poison my patients, because essentially these will kill off the chemo cells, or the cancerous cells, but they also kill off all the healthy cells as well. And this is where the balancing act we have to play, where we want to make sure we get those cancer cells. We have to make sure our patient is able to survive the kind of the aftermath of that. And so we'll talk about some of those complications that occur from that. But you're going to find that radiation therapy is better for tumors you can't really get rid of all that easily, but they're not. They're localized, but they're not really easy to get to. Think about things like brain cancers and things like that, where it's hard to kind of get in there and root that out. But chemotherapy is going to be better for systemic kind of cancers, leukemias especially, and we see a lot of that, especially in pediatrics. So that's kind of what I deal with most often. I should say, people obviously go and specialize in chemotherapy or in hemonc. I'm not an expert in that per se. I do deal with it quite a bit when I'm at Nemours and dealing with a lot of the chemo drugs that we're given to a lot of our leukemic patients. Kids get different types of cancers than adults typically do, so we don't see a lot of things like breast cancer or prostate cancer, but we do see things like brain cancers. We see rhabdomyosarcomas, which are in the muscle. We see all different types there. So that's my extent. But be aware that we may need to, if you talk to an expert, they may have something a little bit different to say. So just kind of keep that in mind. Anywho, so chemotherapy here, again, just note that things like surgery, you can get a large chunk of those cells down, but this is where you need to kind of have repeat therapy in order to make sure you get those additional cells out. And so that's why we have different cycles or different rounds of chemo, as we'll talk about here in just a minute. Okay, so again, because we are typically, these drugs are poisoning our patients to some degree, we want to make sure that we're trying to maximize the risk versus the benefit ratios here. So looking at drug concentrations in the body, looking at exposure times or the frequency of administration, we want to make sure we're killing off as many of those cells as we can while leaving as many healthy cells behind as possible. And then making sure we give time for the patient to recover those healthy cells to make sure that they can do things like fight off infections, or that they can absorb nutrients through the GI tract and different things like that, as we'll talk about toxicities in just a little bit. But the primary thing that ends up kind of killing these patients in a lot of cases, at least what we see in the inpatient side, is you get a round of chemotherapy. What type of cells are going to be most likely affected by chemotherapy? Like slow dividing cells, rapidly dividing cells, right? So you think what type of cells are rapidly dividing in your body at all times? Yeah, so the blood, right? So the blood's going to be taking it here. Here's we'll talk about that. So when you see this depression of white blood cell production, what do you call that? Yes, you can see neutropenia or neutropenia develop there, but we also kind of more broad term is myelosuppression, right? So this myelosuppression is oftentimes the big thing that will kill these patients, because if you get myelosuppressed, what does that do to your ability to fight off an infection? Not great, right? So this is one of those things where infection is oftentimes what ends up being the cause of these patients' demise, not necessarily the cancer itself. At least that's what we see a lot in the pediatric side of things, because kids are pretty resilient. They can kind of bounce back from a lot of things. But once they get one of these infections, and especially if you imagine these patients being immunocompromised, right? You think about like a HIV patient or kind of a late-stage AIDS patient or something like that. They're all kind of immunocompromised to the same degree to where they can't fight off infections, or they get weird infections that normal healthy people don't normally get. So you'll see a lot of fungal infections. You see tuberculosis, see things like that that normal individuals can fight off pretty easily. So you're going to find that typically we'll try to target these cells when they're in the kind of most susceptible phase, and we'll talk about that in just a few seconds of when cancer cells are kind of more susceptible to these drugs. But we typically do really high dose intermittent schedules. This is where basically you give them a big dose of the drug to the patient, really knock down those cancer cells, and then you give the patient time to kind of recover on their own. Sure, there's going to be some cancer cells that are going to be replicating, but the healthy cells will as well. And so you're trying to keep the patient kind of as healthy as possible from that standpoint. And you're going to find that we are looking for the time where a drug is going to be maximally effective, and that's where the cells are going to be most susceptible. So we're going to look at where certain drugs will work in the cell cycle. We'll go back to your kind of basic biology and look back at the cell cycle for just a second here, and also when the tumor's in that growth curve. So if you imagine when you get that kind of that plateau effect there, and again, those cells are not going to be as rapidly dividing, our chemo drugs are not going to be as effective there. Our drugs are going to be much more effective for really rapidly dividing, very quickly replicating cells. And so we're going to be shooting for getting that plateau phase over with, and then hitting those cells as they start to try to kind of recuperate themselves. So looking at our cell cycle, so again, you're going to have several phases here. So we have like G1 phase, we have our S phase, G2. You guys remember what these are? When's the DNA replication actually? Yeah, so there's a little bit during the G1, but really like a lot of the S phase is where you see a lot of the DNA. Yeah, it's where you see a lot of that happening here. The primary thing we're going to see is mitosis is going to be really important here as well. And so just this is a good thing to reference back when you're looking at the chemo drugs and kind of where they're working, is you're going to be seeing that these different classes of drugs work more effectively at different sites of the cell cycle. That'll make sense when we talk about when we actually talk about how these drugs are working based on their mechanism. So it's really important to kind of link that back to what's the mechanism of the drug, how does that affect the cell, and where in the cell cycle is that really working. Some of these are going to be cell cycle non-specific, meaning it doesn't really matter where the cell is in that reproductive cycle, you can hit it. It doesn't really matter. Whereas some of these are going to be much more important to be affecting cells, like say during mitosis or during the actual DNA replication phase and things like that, right? So again, the mitosis, the cell division, we're going to find some drugs will be effective here. Usually G0 is this kind of resting phase. Are a lot of your cancer cells in G0? No, they're always going to be replicating, right? They're kind of they've lost those kind of inhibitory signals to stop replicating. So they're going to continue to do that. See with G1 is where you have the post-mitotic phase where you see some DNA synthesis. Primary site of DNA synthesis here is in the S phase. So we're going to find some drugs are really effective affecting this. And then you have this G2, which is kind of pre-mitotic. So again, big sites here. When you have DNA replication occurring, a lot of drugs are going to be affecting that. And then mitosis is going to be another big one as well. So when we talk about the drugs, you can reference back that slide just a second ago. So again, okay. And again, just remember, anti-cancer drugs are not selective for tumor cells, which means if they're going to be affecting rapidly dividing cancer cells, they're going to be affecting rapidly dividing healthy cells as well. So I mentioned, you know, the hematogenous system being affected very much by these cancer drugs. What other types of cells are rapidly dividing typically?
Like nerves?
Not really nerve cells quite so much. We're going to see some neurotoxicity with some of these drugs, but you imagine like your nerves, like once they're kind of established, like they're kind of done, right? That's why we can't like you know regrow a spinal cord or something like that once it's kind of been severed. Maybe with some advanced therapies and things like that. But what are some other cells that rapidly divide? Yeah, so hair cells are going to be a big one, right? Because again, you think about a chemo patient, what do you think about their hairdo? A lot of times they end up having alopecia. They end up losing all their hair. So that's one of the big things to be concerned about because hair cells are rapidly dividing. What else takes a hit? GI tract's another big one, right? You're going to see a lot of GI toxicity associated with these chemo drugs, a lot of nausea and vomiting, a lot of diarrhea, and then you can have issues with nutrition because they can't absorb their food very well because you're killing off all these cells, and so we'll talk about that a little bit more in a little bit. So again, one of the biggest things you're going into is not only dealing with the chemo drugs you're giving your patients, but also the other drugs that will help to make sure the patients stay healthy, right? So we're going to see some drugs that will help to stimulate blood cell production. We're going to see some drugs that work on the nausea, vomiting. We're going to be looking at some of these in just a little bit, so kind of keep that in the back of your mind. Okay. So again, we'll talk about different types of cell kinetic parameters, and so we will use these terms when discussing what type of chemo should we give to a patient. What's the growth fraction? What are the number of cells that are actually rapidly dividing? Talk about the S fraction. This is the fraction of cells that are in this kind of active DNA replication phase, and this kind of gives you an idea of how aggressive it is. If the high proportion of your cells are all in this kind of S phase, then they're rapidly dividing. They're pretty aggressive. And then we'll also talk about doubling time sometimes to see how long it takes for those cell count to actually double. Okay, so typically when we're looking at the drugs we're going to be giving, we're going to use combination therapy. This helps to minimize resistance because, again, if you think about like antibiotics, why are antibiotics so much less toxic for people than like a chemo drug is? They're more selective. Yeah, they target bacterial cell versus just normal human cells. That's kind of why we lose a lot of that selectivity here. But you also will find that antibiotics, if you were to continually give penicillin to a bacteria, what happens after a while? They can develop resistance. Same thing happens with the cancer cells. So you can develop resistance to some of these chemo drugs by giving multiple different types of drugs, different mechanisms. You can overcome some of that resistance. That's one thing to consider. You can also help to limit some toxicity. And then we'll talk about adjuvant therapy. These help to treat or minimize toxic effects, and these include a lot of like antiemetic drugs, which we'll talk about. We already covered these in GI already, so we'll kind of mention these briefly here. And then also things like stimulating bone marrow growth, right? Because again, we want to help to recover those cell counts as best we can after we kind of knock them down pretty significantly. So the timing of chemotherapy, sometimes we will give drugs that are cell cycle specific, and so you need to make sure you're hitting these drugs or hitting these cells when they're actually in the actively dividing phase. So if my drug is only active at the S phase, I want to make sure I'm giving this drug over a period of time where I'm going to hit the most number of cells as they enter the S phase before they go on to mitosis. So this is where we can do things like giving a continuous infusion of a drug. Sometimes we'll give a drug over, say, a 5-day period to make sure as those new cells get into the S phase, they all get affected, or as multiple doses in a very close time frame. I'll show you an example here of a chemo regimen just a little bit. But again, cell cycle non-specific drugs you can kind of give whenever. It doesn't really matter. They're going to be affecting those cells regardless. And then we'll typically give chemo in cycles. And so these are kind of defined repeating schedules that will occur in order to, and again, this is all done by clinical trial. Usually someone else has done the clinical trial to figure out what's the best regimen for your patient, and that's kind of what you're working off of. And then these cycles also allow for recovery from toxicity, because again, I can't keep giving chemo indefinitely, because that will eventually kill the patient, right? And then also, like I mentioned, clinical trials are the biggest source where we get a lot of this information. If you would imagine which type of clinical trials is more difficult to perform, in adults or in pediatrics? In pediatrics, right? But again, when those things, like, we can't always take that adult information and correlate it one-to-one to a kid's information. So a lot of the kids we have getting chemo drugs over at Nemours, they're all on studies, right? So we have to call the Children's Oncology Group, or COG. If you ever hear of that, that's what we enlist a lot of these patients into these regimens where you either get like arm A of a study, where you get this type of regimen, or you get arm B of this study, and then you will get a different regimen, right? Now, can you do really placebo-controlled trials for that sort of thing? Not very ethical, right? You don't want to give placebo to your patient who has cancer, right? To leukemia. That's not good. So again, there'll be different things like, okay, we're going to dose this drug at this dose, and then the other arm will get this dose of a drug, right? So those are kind of the differences you're going to see in those type of protocols. Oh, Dr. Levine would also be another really good person to talk to about a lot of this, because she dealt with a lot of these patients in the PICU after they got really sick in the HEMONC unit. They come over and see her. So again, you'll find these things where dealing with these pediatric patients is really difficult, because they get really sick, and you got to let them recover. You have to get over the infection. You have to get them to a point where they're healthy, relatively healthy again, to give them more chemo to knock them back down again. So it's really kind of a interesting cycle you have to deal with, and it's very, very difficult to deal with patients. So anywho, this is an example of a chemo roadmap. This is basically the type of thing we'll do. This is for an ALL regimen. So you guys know what that means? Yeah, acute lymphocytic leukemia. So this is an example here. Here's patients randomized to arm A. So this is one arm of a study that they have. And so basically see the different drugs that they're going to receive. And then they have these regimens here. So for instance, when you see CPM, they very similar to HIV drugs, a lot of chemo people, they love to use their acronyms. Again, I'm going to at least put the actual drug name. If there is a brand name available, I'll put that as well. I'm not going to list abbreviations because, again, that's error prone, right? It's one of the problems we have with a lot of chemo drugs. Anywho, so you see cyclophosphamide gets abbreviated as CPM. So they get CPM just on day 1 of this regimen. So you can keep going down. They might get it later on, or they might have to wait till the next cycle to get it. Versus something like Ara-C. Notice here this Ara-C stands for cytarabine. They're getting this for 5 days continuously, essentially, right? And so this is good because we can go ahead and have the nurses document when they've actually gotten the drug to make sure they're actually sticking to the regimen appropriately. Here's like IT methotrexate. When I say IT, anyone know what that means? Yeah, intrathecal. Yeah, so sometimes we'll give, because how easy is it for drugs to cross the blood-brain barrier? Depends, but typically difficult, right? So again, if you have cancer cells that are sitting there in the CSF or in the brain, it can be very difficult to get drugs to cross there. So sometimes we'll give intrathecal drugs directly into the, just like you're doing like a lumbar puncture or something, we'll give it directly into the spinal column, and that will go ahead and hit all those cancer cells that might be residing there. So intrathecal drugs we'll talk about a little bit later as well. So anywho, this is an example of a roadmap. You might see something very similar if you deal with like patients with breast cancer or colon cancer, whatever it happens to be. But this is how we make sure that we stay on target or getting the drugs right when we should be at the right doses and all of that. Also notice here as well, what do you notice about the dosing here for these drugs? We talked about a lot of drugs being given as like milligrams per kilogram. What do you think this means? Yes, so milligrams per meter squared per dose, right? So this is using body surface area. We talked about this briefly when we had the kind of intro pharm course, but again, body surface area is really nice because it helps to eliminate, it incorporates the patient's height into the equation, so that way you get a good idea. Weight is going to be less of an influence on these calculations. So a lot of chemo drugs get dose based on their BS, or patients get based on their BSA, or the body surface area. So that's a really important distinction here. A lot of these drugs get dose based on that, but you might not always see that. So for instance, intrathecal methotrexate, people's spinal column and the CNS doesn't really change a whole lot based on a patient's weight or height necessarily, probably more on height. But you'll notice here that based on the age of the patient, we give the different doses here. So just if they're 1 to 2 years of age, they get 8 milligrams. If they're 2 to 3, they get 10 milligrams. And so you'll see that the dosing changes. And this is why it's so important that we are looking at these roadmaps and we make sure that we're giving things appropriately. And if you imagine, if you imagine being in the hospital setting, or say like an infusion center where a lot of patients get these drugs, if you write an order for, say, Zofran for them, you write an order for Zofran, goes to the pharmacy, they verify it, the nurse goes and grabs it from the machine and gives it to the patient, right? So there's some checks there, but not a whole lot of checks. Versus chemo drugs, because these are so potentially toxic to our patients, you have to have 2 providers that will sign off on the actual drug orders, right? So original person writes for methotrexate, the second person goes and will also verify it to make sure it's correct. You will have 2 pharmacists that will check it, and then you will actually have 2 nurses that will check it off as well. So notice here is double the number of checks that happen because these drugs are so dangerous, right? So again, you should keep that in mind, that it's very important that we miss drug errors here, because this can be really traumatic to the patient. So we'll also look at some other types of therapies. There are going to be assigned some that are going to be targeted therapies, and these are going to be actually focusing on very specific extracellular receptors. And so we're going to find here you'll have things like antibodies potentially that will target certain receptors, or maybe possible growth factors. So we'll talk about those a little bit later briefly. And then biologics. And so these kind of go back to our monoclonal antibodies, which we've talked about previously, right? You guys remember like we talked about like Crohn's disease and ulcerative colitis. We had like infliximab or adalimumab. Those are monoclonal antibodies that had very specific targets. You're going to find some of these drugs being used here as well, and a whole lot of other ones. I'm not going to go into very lot of detail on these biologics, because again, you just need to know the basics of them, because there's brand new ones being produced all the time, right? So we'll talk about those very briefly as well. Again, a lot of times these biologics are being used to help kind of boost the body's own immune system to try to fight off these cancerous cells. Because again, your body can produce kind of mutant cells all the time, but your body's able to fight that off in a lot of cases. Sometimes we have to help boost the patient up to make sure they can fight off these cells as well. Anywho, all right, and again, obviously early detection and treatment is obviously going to be best for the patient. The earlier you can catch something, the better. So this is why patient education is super important. Make sure they get their breast checks and testicular checks and colon screenings and all that kind of good stuff, based on your patient. And with toxicity, make sure that we're going to see that cells that have the highest growth rates are going to be the biggest ones affected. So again, looking at neoplastic cells, yeah, they're going to be affected pretty significantly, but also we mentioned the bone marrow, GI tract, the hair, even the reproductive cells get hit as well. So again, it's one of the things where patients may have kind of a reversible things like, it may have a decreased spermatogenesis, may have menstrual irregularity. Some of that is reversible. Sometimes it may not be in some cases. So just be aware of that, this is not going to be a time frame where patients are going to be looking to get pregnant in a lot of cases. And again, if you had to imagine, we talked about teratogenicity of drugs, how teratogenic do you think these chemo drugs are? Very much so, yeah. So again, these are not drugs you want to give to pregnant patients by and large. Okay. There's also a lot of mechanisms of resistance. We're not going to talk about this too much, but just know that these look very similar to how bacteria produce resistance to drugs. And so the cancer cells can do this as well, which is why you may need to change therapy, you may need to change your dose, different things like that. And so sometimes we can look for these things by doing certain genetic testing. A lot of times you cannot do that, and so you just have to kind of monitor how the patient responds and then kind of go from there. So again, also the idea of your goal of therapy. So again, we'd like to be curative whenever possible, but is that always going to be realistic? Not always, right? And so when you kind of get to that end of life type of care, we call that palliative treatment. So sometimes we're just trying to help to increase the quality of life of the patient, not necessarily the quantity of life, right? And so it's one of those things where you may be giving kind of compassionate use of chemotherapy just to kind of help alleviate some of the symptoms for the patient rather than actually having a goal of being curative in a lot of cases. So just be aware of that. There's kind of two different modalities there, versus trying to be curative and increasing quantity of life versus quality. Okay. So let's do a 10-minute break now. We'll come back and then try to get through these chemo drugs. Okay, any questions on the first half? Now we kind of got the basics of talking about chemo. Now we can actually talk about the drugs themselves. So keep in mind, I'm not going to ask you for this type of leukemia, what's the best drug? There's not kind of questions. This isn't really as easy to cover in that kind of format as like hypertension or diabetes or something like that. So this is going to be more so recognizing the drugs, being able to establish what their mechanism of action is, what type of side effects are most associated with those drugs, and any antidotes that come up. That'll also be kind of another big point. As you'll see when you look at the quiz, those are kind of the primary things we're kind of hitting on there. So those are the kind of questions I'll kind of be asking. Those kind of the points we'll be looking at. And we'll get into more detail on that in just a second. This is another really good slide here that kind of gives you an idea of where these different drugs are going to be acting. We're going to talk about the... Oh, I'm sorry. Perhaps I should display it on the thing. You're supposed to be psychic and kind of know what I'm pointing at any moment. There we go. Okay. So anyway, this is a good slide. It kind of gives you an idea of where these different drugs are going to be acting at based on their mechanism. And so this is a good thing to reference back. We'll talk about all these in detail as we talk about them. Also note this is a non-exhaustive list. I'm going to list kind of the more common ones you're going to run into, but especially with the biologics, that list is rapidly blowing up, and there's no point in kind of going over it because again, I don't expect you guys to know Ogalimumab versus Alemtuzumab versus there's too many mAbs that are out there right now, and they're very specific in their uses, as we'll talk about when we look at a few example cases. But these ones we're going to talk about right now primarily going to be very broad spectrum. They're going to work on lots of different types of cancers because of their mechanism. So first ones we're going to talk about are called anti-metabolites. And so basically these are going to be very similar drugs. They're very similar to the nucleotides that make up DNA and RNA. So when I say nucleotides, what am I talking about? Yeah, so purines, pyrimidines, and more specifically when we're talking about DNA, we're talking about guanine, cytosine, adenine, thymine. Yeah, so we're talking about all those as we get into them and where these different drugs, how they're mimicking some of these nucleotides and how they're affecting DNA reproduction, in some cases RNA reproduction in some of these cells. Your body can't really tell the difference between these mimics, essentially, versus the actual naturally occurring nucleotides. So it's very easy for these cells to incorporate them into the DNA. Once they get incorporated into DNA, they are structurally different enough to where they actually cannot continue elongation of that DNA. So that's kind of a problem because if the DNA senses that it can't add anything to it, we call those chain terminators, where it cannot allow for the DNA to continue to replicate further downstream. That leads to a triggering of apoptosis, right? So once it gets there's a signal, there's enough damage done to that DNA where things like DNA polymerase can't come and fix it, and it says, screw this cell, we're going to go ahead and kill it off, and we're done with it, right? So that's how a lot of these anti-metabolites are going to be working, as we'll see in just a minute here. So they will disrupt that replication cell division. They are going to be non-specific and non-selective for cancer cells. So again, these are going to be affecting rapidly dividing cells as well, which is going to be good for a lot of those leukemias and things like that. The three main categories we're going to talk about include the pyrimidine analogs, the purine analogs, and then folate antagonists. The folate antagonists, we've already talked about one previously when we talked about like rheumatologic stuff in GI. So you guys remember methotrexate? Remember, that's a folic acid antagonist. That's going to come up here again as well. And this is one of the more one of the primary uses we see for methotrexate is for cancer treatment. So anywho, first off, we're going to be our pyrimidine analogs. So if you imagine, I'm not going to have you draw these out on the test. That would be very mean. I had a whole class called medicinal chemistry. We had a full 2 years of it in pharm school where we actually had to draw out these kind of reactions and these chemical structures. Yeah, it was miserable. How often do I use that nowadays? 0. All right. Anyway. So you imagine cytidine, this is a normal nucleotide that will get incorporated into DNA. If you imagine something like deoxycytidine, this is actually where it gets incorporated into the actual DNA itself, where you notice the kind of that sugar chain, that deoxyribose, is going to be what kind of forms the backbone, and then you have the nucleotides that get involved in that. If you notice here that cytosine, arabinoside, or otherwise known as cytarabine. So again, there's lots of different names for these drugs, but Aracy or cytarabine it has a little bit different of a structure. So just adding in this hydroxyl group right there is enough to screw up the whole process of actually making new DNA. So, but it looks similar enough as you imagine looking at these structures that it can get incorporated pretty easily. So again, it's a cytidine analog. It gets phosphorylated, and then by incorporating into the DNA, it inhibits DNA polymerase, right? So basically, you cannot extend that DNA strand any further. You cannot add any new nucleotides to that, and so that can be very, very useful for kind of triggering off apoptosis. Now, I'm just going to list the routes out here just for kind of illustrative purposes. You don't necessarily need to know whether this is an IV versus intrathecal drug. Just know that there may be different routes you can get these drugs by. So if you ever see something that says IT, that means intrathecal. If you see something IV, then it's going to be an intravenous type of drug. We also have some oral medications we'll talk about as well. But this is a common one we'll use intrathecally. There's going to be a few drugs we'll talk about a little bit later that can be fatal if given intrathecally. So that's a really good point to remember as well. This is not one of those. This is one we use pretty commonly though. And again, don't know the indications necessarily. I'm just kind of listing these as kind of just example where you might see some of these being used. But you can use pyrimidine analogs for a lot of leukemias. So we use cytarabine quite frequently for a lot of our kids. Now notice that with the toxicities, very similar to how things like antibiotics cause a lot of nausea and vomiting. It's not really helpful to realize, okay, penicillin causes nausea and vomiting, cephalosporins cause nausea and vomiting. You just kind of know that in general, one of the dose limiting factors for all these chemo drugs is going to be leukopenia, right? Because again, these are going to be affecting not only your healthy cells or the cancer cells, but also your healthy cells. So leukopenia and thrombocytopenia are big things you're going to be monitoring for, because if the patient gets down too low, they could be at bleeding risk, it can have a risk for infection, and so this oftentimes will hold the patient up from getting another round of chemotherapies based on this myelosuppression that happens here. And so we oftentimes will say certain regimens are count dependent, and so a lot of times what you're doing is you cannot give a new round of chemo until your patient actually makes counts, meaning they have enough neutrophils that they can fight off infection, they have enough platelets to make sure that they can actually coagulate appropriately, right? So other big side effects you're going to notice of these is nausea, vomiting, and this is going to be kind of a universal thing. We'll talk about emetogenicity in a little bit later, but just know that some chemo drugs are very noxious and they cause a ton of nausea and vomiting. Some other ones are going to be a little less severe. So we'll talk about that in a second. No point in memorizing that. Just know that they all have a risk for nausea and vomiting with these kind of these really non-specific sort of chemo drugs. And then some other unique things to note here with, say, cytarabine, you can see the cerebellar syndrome, especially with large doses. So you can actually see some neurotoxicity where they're having dysarthria, nystagmus, and ataxia. You see this more often when patients have renal dysfunction. They end up holding on to too much of it, especially with the big doses, and you can see some of that issue that pops up there. And then also some conjunctivitis and keratitis. This is things where you want to be careful, make sure they're actually getting things like saline eye drops at the very least, because otherwise that can lead to, possible ulcerations, abrasions, things like that. Or in some cases, we actually have to use steroid eye drops to make sure that they're staying hydrated well enough. So one thing you see kind of unique with cytarabine. Another kind of closely related pyrimidine analog is going to be gemcitabine or Gemzar. Again, I'm just really going over the more common ones we run into. This one's very structurally related to cytarabine. Notice here the only difference is instead of the hydroxyl group being added on to that ring, you actually have 2 fluorides added on there. And again, fluorides is not very commonly seen in DNA or ever, and so that kind of screws things up for the DNA replication again. So you can see very similar mechanism. It's just doing it with a little bit different chemical structure there, right? So again, notice it has very similar toxicities, myelosuppression, nausea, vomiting associated with that, and then occasionally you can see some flu-like symptoms coming up with this. So if you ever have like the kind of myalgias and kind of low-grade fevers, you can treat that with acetaminophen. It's usually the more common one to give. Because again, if you imagine if I have a patient who's thrombocytopenic, would I want to give them an NSAID necessarily? Not typically, right? Because that's going to potentially mess up platelet function, at least temporarily, unless you're giving something like aspirin, right? Because remember that COX inhibition affects platelets aggregation and all that. Stuff's going to get pulled back from semester 1, so don't forget all that stuff. Don't just repress those memories. Bring them back and bathe in them if you must to remember all this stuff, because it's going to come up again, right? Right, so then we also have some pyrimidine analogs as well. So this is going to be one of my favorite drugs to abbreviate, because fluorouracil, you can always say, hey, my patient, 5FU, buddy, right? So you can give them some of that. Also, another one that gets converted into 5FU is going to be capecitabine or Xeloda. And so basically, these are going to be false pyrimidines. And so we'll look at this mechanism here a little bit, but this is basically how we're going to get thymidine is being formed here in this process here. So this is a very important process. This will come up again when we talk about methotrexate, which is what abbreviated as MTX. But basically, we're using folic acid in order to produce thymidine, essentially. And so by screwing up this process, by giving something like 5FU, it's going to be inhibiting thymidine synthesis, thymidine formation, and then it cannot get incorporated into the DNA. So again, if you deplete the pyrimidine, cannot get incorporated into the DNA, again, DNA replication cannot occur. So that's one of the big ways this works here. The other thing is if you depress function or production of thymidine, you also can affect RNA production as well. So kind of a dual mechanism you see there. Again, notice here, very similar, dose-limiting leukopenia, diarrhea, mucositis. Well, when I say mucositis, anyone know what that is? Not necessarily swelling, but you see a lot of ulcerations that occur in the mouth, and so you see a lot of breakdown of the GI tissue, the mucosal tissue in the mouth. Why do you think that's problematic? Can't swallow, right? So it's really painful for your patients, right? The other thing is when you're having breakdown of that tissue, what could also potentially translocate? Bacteria, right? And so patients are already going to be neutropenic. They're going to be more immunocompromised. So again, you can see infection. This is why oral hygiene is super, super important for these patients, especially if they're experiencing mucositis. The other thing, if they can't swallow very well, guess what? They can get dehydrated. They may not be eating very well, so they may get their nutritional status being affected. Again, so lots of different things can happen from this kind of this oral kind of complication of chemo drugs. But just know that, again, you can see that cerebellar syndrome pop up here a little bit. And then also with 5FU, you can see this hand-foot syndrome. Anyone know what that is? Basically, it's kind of these peripheral neuropathies, and typically you're going to be hitting kind of the longest nerves that get affected most. I'm not really sure why that is, but typically you imagine nerves running through the spinal column out to the periphery, especially like in the distal portions of the foot, like in the toes and things like that. Those nerves get affected, and so you can end up seeing some paresthesias. You can have numbness that develops there. The hands are also going to be affected as well. So we call that hand-foot syndrome when you see these peripheral neuropathies that develop. We'll find some other drugs that do that as well a little bit later on. And again, you can see some conjunctivitis associated with this one. Yes, ma'am?
Why does the versus the
Because 5FU is going to be primarily an IV medication versus the Xeloda can be an oral medication. Yeah, so usually 5FU doesn't get absorbed very well, but the capecitabine can be and then get converted over. Good question, though. Okay, then moving on, then we have our purine analogs. So these are going to be mimicking basically things like adenine and guanine, essentially, right, instead of cytosine and thymidine. So we have 6-mercaptopurine, or 6-MP, as it gets oftentimes abbreviated, and they also have thioguanine. Again, very oftentimes used for leukemias and whatnot. We use it very, very commonly. And these are going to be affecting purine synthesis, right? So basically by preventing their formation of adenine and guanine, again, cannot be incorporated into the DNA, or these themselves will be directly incorporated into the DNA, and then you cannot have any further elongation of that chain, right? So again, you kind of start to meld some of these, these anti-metabolites, all have basically the same mechanism. The details are to kind of delineate whether it's purine versus pyrimidine, but basically they're all preventing DNA production, right? So if you arrest that DNA production, you lead to cell death eventually, right? Now, other toxicities you're going to see with this one, the big is hepatotoxicity, and then again you can see some myelosuppression. Oftentimes this is due to some of the toxic metabolites that form here, but these are two of the big ones we worry about. What's kind of interesting is that you guys remember pharmacogenetics? What is that? So basically your genes affect how you handle drugs, right? So it can affect the metabolism of drugs. Remember we talked about like hydralazine, and we talked about things like isoniazid, how that can affect your acetylation pathway. Some people are fast acetylators, some people are slow acetylators. Same thing can happen here, where essentially you can have changes in expression of certain genes that lead to worsened toxicity. So this may be something you monitor for some of your patients prior to them getting these medications. Okay, so we have our purine, pyrimidine analogs, and we have our folic acid antagonists. So now, methotrexate itself does not actually get incorporated into the DNA. It's not actually mimicking any of those nucleotides there. But what this actually does is inhibit the utilization of folic acid, right? So we'd already talked about this previously. And again, if you imagine, if we go back to your GI lectures when we talked about like Crohn's disease, what was the major side effect of methotrexate? You see myelosuppression, right? Because remember, this makes your patients immunocompromised, because with Crohn's disease, the ultimate problem is the patient has this kind of self-inflammatory reaction, right? So you're, in order to tamp down that inflammatory reaction, you have to tamp down the immune system, right? So we're using it for the same purpose here. Typically, though, with the methotrexate being used for cancer, we use a lot bigger doses, because really, if you're using for something like leukemia, you want to wipe out all the white blood cells, or at least the highest percentage you can, in order to make sure you get rid of as many of those cancer cells as possible. Versus something like a rheumatologic condition like Crohn's, you just want to kind of just tamp it down a little bit. You just want to try to blunt that inflammatory reaction that your body's having against kind of inappropriate targets like the colon or whatever it happens to be, right? Kind of make sense? So basically what this is doing is it inhibits this dihydrofolate reductase, this DHFR. So you can imagine going back to this this thymidine synthesis prior to getting incorporated into DNA. We have methotrexate here that prevents this this change from dihydrofolate over to tetrahydrofolate. So just know it's a folic acid antagonist. It prevents your cells from utilizing folic acid appropriately, which can lead to cell destruction eventually. Because if we can't form those new nucleotides, it cannot form new DNA essentially, right? So you see, this will affect purine synthesis, have decreased RNA and DNA production, lead to cell death. So the other nice thing about methotrexate is it can be given via different routes. So we saw that we can give this orally for a lot of our like rheumatologic condition patients, but we can give this intrathecally, IV, orally. So it's kind of a pretty versatile drug. Very old drug that's been used for a long, long time because of its efficacy here. And you kind of notice here folic acid versus methotrexate has very similar structure. Again, you can kind of rotate and kind of see how they look similar, but not quite the same. That is just enough to disrupt that whole kind of metabolic process there. So as far as toxicity goes with methotrexate, there are quite a few. So again, you still see myelosuppression and GI toxicity. Well, one of the big ones you see here is hepatotoxicity. So I remember my aunt was diagnosed with breast cancer. She was very upset when they put her on oral methotrexate every day because she couldn't drink her wine anymore. She was very sad about that. But because of this hepatotoxicity that can occur, it could be aggravated by alcohol consumption and things like that. So hepatotoxicity is a big one. The other big thing you see is renal toxicity. Methotrexate has a tendency, especially in more acidic urine, to crystallize out. It precipitates out of the solution, and so you can end up seeing basically precipitation leading to crystal urate, can lead to renal dysfunction. So this is very important that when we talk about antidotes for these drugs or certain supportive therapy, a lot of this is being given to prevent these adverse effects. So again, if the methotrexate is primarily renally eliminated, but then the methotrexate is precipitating out, screwing up the renal function, you hold on to all that methotrexate, and then what can happen? Myelosuppression, you see more hepatotoxicity, you can see all these problems that develop, and so that's why it's really important that we're looking at how well the patient can clear these drugs, because that may be precluding them from getting the drug in the first place. So if you have a patient who has new onset renal failure, you might not give them methotrexate because of this problem. So basically what we're going to do is we're going to give them certain antidotes that can help to prevent any problems. So one of the things we do for the renal function issue is we give them sodium bicarbonate. I mentioned that too acidic urine will cause it to precipitate. Let's alkalize it. Let's give them sodium bicarb. Let's increase that pH, and that will help it to be more soluble. And so we will give this concomitantly with methotrexate to make sure they can clear it out of the kidneys very easily. Right? That's one thing we'll do. Another thing we can do to help our healthy cells is give basically an activated form of folic acid, right? So folic acid gets converted to folinic acid, and then it can be utilized by these cells. Basically, methotrexate prevents this activation step. So what happens is you'll have a patient who gets a big dose of methotrexate. Their healthy cells, along with cancer cells, cannot use folic acid very well, and that leads to cell death. After the patient gets some methotrexate, then a period of time after that, we'll actually give them folinic acid to help their healthy cells start to utilize that process again and kind of reestablish normal cell replication. So if you ever hear like a leucovorin rescue, that's what we're giving is folinic acid. Basically, that helps to help them recover their healthy cells by letting them utilize this activated form of folic acid, right? So again, if I were to have on a test and I say, okay, patient accidentally got too much methotrexate, what would be an appropriate antidote? If I put folic acid on there, that would be incorrect because the cells cannot use folic acid because it can't be activated due to the methotrexate actions, right? And then the other one we'll use very rarely is this, basically it's a protein we form an enzyme called glucarpidase, and this is actually a direct metabolizer of methotrexate. So go in and cleave that drug and lead it to be inactive. So this is a very expensive drug that we'll use occasionally. Patients who develop renal failure and can't clear it, or they have very, very high levels. Like say, for instance, they got it was given incorrectly and they got a way higher dose than what they should have. We'll use this. I think a dose of this runs somewhere close to like $100,000 or something like that. So very rarely used, but good to know in case you ever have an issue where it needs to be given. You can reverse the toxicity here. Yeah. Again, be able to look at the antidote, link it back to the drug that you can use it for, and how you might use it and what it can help to prevent. Right. So that's important. So that's dealing with the actual nucleotide formation, looking at those antimetabolites. Now we're going to be looking at drugs that affect the microtubules. You guys know what microtubules are? Part of the cell skeleton, essentially, right? So these nice little tubes that will go throughout the cell to help to give it some form and structure. It'll be really important, but how does it help with mitosis? Let's go back to those like biology pictures where you see like all the chromosomes lining up along, they get all lined up along the cell right in the middle, and then you have the microtubules pull them apart. So if I affect that, if I either prevent the microtubules from forming, guess what? Those chromosomes never divide, and you're stuck in mitosis. If I prevent them from being broken down, guess what? The cells cannot effectively undergo mitosis, and then you're kind of in the same pot, right? So again, by affecting microtubule formation, you can help to arrest cells in mitosis and then prevent them from replicating. So again, this is a very good example of a cell cycle specific set of drugs because they're only going to be affecting cells when they're in mitosis, right? Well, affect them when they're not really producing a lot of new microtubules during RNA, or, DNA synthesis. It doesn't really work there. Only in mitosis. That's really important to keep in mind there. So anyway, so we help to prevent that mitotic spindle formation, and we're going to find that primary drugs that affect this are going to include our taxanes and our vinca alkaloids. So these are two primary classes we'll talk about here in just a second. So, anyone know why I put a picture of a tree here? Anyone know what tree that is? This is a yew tree, not a me tree, but a Y-E-W tree. And basically, this is actually one of the sources. So a lot of drugs we have nowadays have some of their roots, no pun intended, back to certain plants, right? So like aspirin comes from like the willow tree and things like that. This is another set of drugs that actually come from some plants here. So this is the Pacific yew, I believe, that actually helps produce our taxanes. And this is why we call them plant alkaloids, because they have this kind of plant origin here. But the two we have here is called paclitaxel and then docetaxel, okay? Their primary thing they're going to do is help to promote the formation of the microtubules, but then you can't break them down. So even though you can form them, they can try to get ready to sort of pull those chromosomes apart. If you can't break them down, you can't really finish mitosis, and then you're kind of stuck. Once the cells are stuck in mitosis, it realizes, hey, nothing's going on here. Let's just go ahead and kill the cells off, right? So, so big things you're going to see as far as toxicity goes, you can see myelosuppression for both. Obviously, again, this kind of goes for all these chemo drugs. And then for docetaxel, an interesting thing you see is fluid retention. That can be problematic, especially if a patient has kind of like what disease state could be a problem. CHF, yeah, or renal failure or anything like that where they're holding on to fluids already, that could be a problem, right? That may lead you to not use that drug. And then paclitaxel is another big one for causing neurotoxicity. So these are peripheral neuropathies, the hand-foot syndrome we kind of mentioned, and then also potential risk for hypersensitivities who would want to watch for like anaphylactic reactions and whatnot. Now what we can do is give pre-treatment. So some drugs you actually give pre-treatment before they actually get the chemo to help alleviate some of these problems. So for instance, if I know they have a risk for having an anaphylactoid or anaphylactic reaction, I can give them steroids beforehand, right? I can give them things like Benadryl beforehand. You guys remember going back to our anaphylaxis talk, right? The drugs you give for that. So, H1 antagonists, you're going to give corticosteroids. And then if you have a reaction, that's when you give what drug? Epinephrine, right? So that's where you'd use that. You'd hold off on that one. It's usually not a pre-treatment drug, but certainly steroids, H1 antagonists, that would be something that's good to use. And that helps to limit some of those side effects there. And on the flip side, anyone know what kind of plant this is? The vinca plant. Anyone know another name for it? Periwinkle is another name for that one. So again, not going to be on the test, but just useless trivia for you. So 3 drugs that go in this category are vincristine, vinblastine, and vinorelbine. So it's kind of easy to put those in that vinca category because they all start with VIN, right? And so again, you can see some of their abbreviations. I hate abbreviations in medicine because again, it's very easy to get those stuff screwed up, right? So if you're talking about VBL and someone actually says VCR, again, most of you guys probably don't know what a VCR is anymore. But for those that do remember, have you guys ever had like the little machines that would rewind the thing for you? It had like a little car that you would put it in and the headlights came on. Anyway, so these are going to be affecting the microtubules, but from a different standpoint than the taxanes. Basically, this will bind to tubulin and prevent the actual formation of the microtubules. So the taxanes, they prevent a breakdown of the microtubules. This actually prevents production of the microtubules. So again, cannot complete mitosis and leads to cell death eventually. Now, as far as toxicities go, just note that this is one of those ones that I mentioned. It's fatal if given intrathecally. And so this is a big thing we have to watch out for because, if you see a warning for something, if you see something like, hey, don't do this really easy common sense thing, why do you think that sign was made? Because someone did it, right? So it's one of those things where, for instance, when we're giving chemotherapy to our kids, right? So oftentimes they're getting intrathecal methotrexate the same time they're going to be getting IV vincristine. And so that can possibly get screwed up. So we take steps in order to make sure that doesn't happen because of the risk of giving vincristine intrathecally is potentially fatal. We have to be really careful with that. So we do things like, for instance, with a drug given intrathecally, you give it via syringe, right? So you're going to have it in a syringe, you just and once you establish the lumbar puncture, then you can put it in. Versus this one, we would only give it in a bag. Right, so that way it's in an IV bag, can only be hooked up on a pump. That way that's kind of visually, you make sure you don't screw that up, right? And then this is why we require so many checks on this stuff, because again, you can kill somebody. So just note that, fatal if given intrathecally. And then also note that vincristine especially causes a lot of neurotoxicity. So not only do you see this kind of hand-foot syndrome, but you can also run into certain of the, some degree of the enteric nervous system being affected. And you see a paralytic ileus and constipation. So that's another big side effect to worry about. We had one patient who was complaining of very severe constipation. We actually prevented them from getting more vincristine because of that neurotoxicity. It's not the same kind of like, kind of benign constipation you see patients getting opioids after surgery. This can be, something that could be potentially non-reversible in some cases. That's why we got to monitor for that sort of thing. And then also, anyone know what a vesicant is? I don't know if I mentioned this previously. Yeah, it causes blisters, right? So this is certain drugs. If you were to give it via an IV, so establish an IV, if that vein blows, or for some reason you start to infuse that drug outside of the vein, once it gets in that subdermal tissue, that subcu tissue, you can see damage start to form here, right? Because again, these drugs are trying to damage these cells, and it can happen very rapidly, especially if you inject into that kind of subcutaneous tissue. So this is one of the things where it's really important you're monitoring the patient. Nurses should be watching for this to make sure that the drug is infusing appropriately. Make sure you're not going to extravasate those drugs, because that tissue damage can be, in some cases, very, very problematic. Sometimes it can lead to amputations in some severe cases. So you got to be really careful with this stuff. Every hospital or everywhere where you're going to be infusing these chemotherapeutic drugs, they should have a extravasation policy that actually will list out like what you should do. Because some drugs will require cold compresses, some require warm compresses, and sometimes they'll actually have other drugs that help them to dissolve better and get absorbed into the systemic circulation a little bit easier. So just be aware, very severe ulceration of the skin. You can see a lot of tissue damage being done here, sometimes requiring wound care or surgery. This is not good, so you want to be really careful with or vesicants like this. And just to give you an idea of this microtubule formation, just remember they're working at different protein sites on the microtubules, but just know that the taxanes are going to be working on blocking disassembly. Vincas are going to be working more on preventing formation of it. Just kind of keep that in mind. Next off, we're going to have some topoisomerase inhibitors. Anyone remember topoisomerase? We were talking about that last. Antibiotics. Which ones? Fluoroquinolones, yeah, absolutely, good. So the fluoroquinolones were topoisomerase inhibitors, but keep in mind that the topoisomerase that a bacteria has is different than what the humans have, right? So because of that, you can have fluoroquinolones that are very selective for that. However, we can also have topoisomerase inhibitors that work on human cells, hopefully work on cancerous cells. And so we can give this, and you guys remember what topoisomerase did? Yeah, it would cause strand breaks. It would allow for that super wound DNA to relax a little bit, to allow for things like DNA replication, or to allow for RNA production, things like that. And so if you prevent that, you can either lead to increased number of strand breaks, or you may prevent that from actually being unwound in the first place, and that can lead to triggering of that apoptosis. So these are important. There are two varieties of topoisomerase that we target here. There's 1 and 2. Just an easy way to remember is that topoisomerase 1 just works on single strand breaks. Topoisomerase 2 does double strand breaks. Not super important for our purposes. Just know that certain drugs will target one versus the other. I'm not going to quiz you specifically and say, well, which one does 1 versus which one does 2. I'll mention it here, but just know that whether or not it's active at affecting topoisomerase is the important thing. But basically, we're going to have a couple of drugs here that work on this. We're going to have our epidophalotoxins, it's kind of a mouthful, of our Anthro Cyclins, and then our Chemotherapeutic. Those are the 3 groups that are going to fall into this topoisomerase inhibitors. So basically, with our epidophalotoxins, these are also going to be plant-based. This actually is from the mandrake, and so we have the topicide and the tenipicide. So that PO kind of gives you an idea, is an epidophalotoxin. And so these are going to be binding. They have a minor action where they actually bind to tubulin and inhibit microtubule formation, but the primary thing that it does is actually affect topoisomerase 2, so leading to further strand breakage of the DNA, eventually leading to cell death by triggering off apoptosis. Big thing just to note here, dose-limiting myelosuppression, nausea, vomiting, but this one you can also see a lot of alopecia with as well. This is actually very similar in action to, you guys ever heard of colchicine? We'll talk about that more when we get to the probably to the osteoarthritis section. We talk about gout and all of that. We haven't talked about that yet, right? Sorry, the classes get all mixed up. But yeah, we'll talk about that later. We talk about colchicine, but just know that it kind of has its roots back in kind of these type of drugs. But next we'll have our Anthro Cyclins. These are kind of interesting. I put a picture here. You notice the color. These are bright red drugs typically. So if you ever see an IV bag, it looks bright red. It's probably not blood, but it could be what is Anthro Cyclins, excuse me. So we have 3 main ones here. We have doxorubicin, we have daunorubicin, and then mitoxantrone. These are going to have the mechanism of inhibiting topoisomerase 2. What's kind of interesting, which I think is one of my favorite words to say, is it intercalates into the DNA. So that intercalation basically means that it has this very kind of flat planar structure, as you kind of see here with this 4-ring structure. Basically kind of just juts itself in between the DNA and prevents things like replication from occurring at that point. So the other thing is it produces free radicals. Anyone ever heard of a free radical before? What is that? Very reactive, usually it's oxygen, right? So very reactive oxygen species. What can free radicals do? It can cause cancer, absolutely, yeah, because they go and they bind to proteins, they bind up to DNA, they cause all kinds of changes and damage wherever they go. Now, our body produces some free radicals normally, but we have means of dealing with that. We have things that are going to be, that can react with it, and it's generally safe, right? So, but in this case, we're producing new free radicals that can cause damage to the tissues, and this will be important when we're talking about one of the side effects you see specifically with anthracyclines. Damage to good tissue, bad tissue, yeah, really non-selective, which is one of the things. So free radical formation is really can be deleterious to your patient if it's kind of happening in a kind of non-controlled sort of manner. Now, the main thing you're going to see with this, obviously myelosuppression, but the big thing is unique to the anthracyclins is going to be this cardiomyopathy and potential formation of CHF or development of CHF. Basically, what happens is that the cardiac tissue does not have a certain enzyme. Basically, this ability to detoxify the free radicals, because it lacks this enzyme. It cannot get rid of the free radicals. You see cardiac damage that occurs here, and so if you give it for too long a period of time, they get too big of a dose, you can see kind of this irreversible cardiomyopathy that happens here that eventually leads to CHF. And so what we'll do is we'll have a lifetime max dose that the patient can receive. I'm not going to have you memorize what that is, but just know that once a patient receives, say, 550 milligrams per meter squared of doxorubicin, they can never receive that drug ever again, because that risk of having that cardiomyopathy is too great at that point. Okay. This is one of the rare cases we have a lifetime max dose of a drug you can ever receive. Oftentimes we'll do a baseline echo to see what their cardiac function is prior to getting the drug, and that way you can look for any changes that occur over time. So be aware of that. Alopecia, so again, this is another big one that causes a lot of alopecia. And then because of that red color, you can see discoloration of the urine, the sweat. So again, it's one of those things where, anytime you change a patient's urine color or poop color, you should probably give them a heads up beforehand, because that can be pretty distressing if all of a sudden their pee turns red. They probably should know it's not blood, right? And these are also very strong vesicants. They extravasate. They can cause very, very severe tissue damage. You got to be watching out for that. As far as antidotes go, this one has one called dexrazoxane, and basically this is kind of interesting. This is a chelator. You know what a chelator does? Yeah, binds. Yeah, so basically it's going to have chelates iron to actually help prevent this free radical formation. So that can be cardioprotective. So for some patients who are really high risk, we'll give dexrazoxane in order to help prevent the free radical formation. It can still work on all those cancerous cells, but it leaves the heart relatively unscathed, so to speak, which can be very, very useful for your patients. And we have the camptothecans. This is going to include topotecan and irinotecan. These are going to be affecting topoisomerase 1. This one is kind of interesting because irinotecan specifically can decrease cholinesterase activity. You guys remember what cholinesterase does? The name is acetylcholinesterase. So it breaks down acetylcholine, right? So acetylcholine is very important for helping our parasympathetic nervous system to function. If you have too much acetylcholine, what can happen? We talked about you have all these secretions that happen here. You have too much activity on the GI tract. You can have salivation, urination. Remember with those dumbbells? I think at some point. Yeah, you can see. Actually, you'd have mitosis that would occur with too much cholinergic activity. Anyway, point being here is that with irinotecan, it decreases cholinesterase activity. That leads to more acetylcholine, and that leads to very severe diarrhea. So this is one of those things to note here, very significant. Because, again, too much diarrhea, it can lead to things like dehydration, may not be absorbing their food very well. So that can lead to some complications with that one. So just be aware, irinotecan is really well known for causing diarrhea. You'll see that if you look back at Chemo Man, it's probably what was coming out of the bottom of them, if I had to guess. Again, myelosuppression, nausea, vomiting, again, very, very similar to a lot of these other chemo drugs we talked about. Okay, and then one of the last big groups we'll talk about as far as kind of these non-specific sort of chemo drugs is called the alkylating agents. Anyone know I put this picture up here talking about mustard gas? So mustard gas was used back in World War I. It was a chemical warfare agent. It was very, very bad because it was a very strong vesicant. It would cause very severe tissue ulceration. It would also cause actual DNA damage and led to some cancer itself. Oh, that's the other thing to know. So remember we talked about antiarrhythmics, how anytime you give an antiarrhythmic, it can actually cause an arrhythmia? Same thing here with chemo drugs is that any chemo drug potentially cause mutations in the DNA and actually cause secondary cancers. Another thing just to be aware of. But essentially, this is one of the oldest and kind of the most useful classes of chemotherapeutic agents. It was developed back a long, long time ago. And if you guys ever look at one of the textbooks that we use a lot in pharmacy, it's called Goodman and Gilman's. These are the two guys that originally discovered these mustard gases or at least discovered them as a use for chemo or for cancer, I should say. Basically, what these drugs are going to do, imagine they're called alkylators. They're going to bind to some of the nucleotides within DNA. So basically, go in, they'll bind to the DNA and cause this kind of conformational changes that lead it to be pretty much useless at that point. Cause more strand breakage and cause all kinds of problems to eventually lead to cell death. These are very non-cell cycle specific, meaning they can work anytime you give them to any kind of cell, and which also means that they have a lot of kind of widespread toxicity because they'll affect a lot of healthy cells as well. So while these are very effective at killing off cancer cells, they are also very good at killing off your healthy cells as well. Just know these are all cytotoxic, killing off the cells. They're mutagenic, which means they can cause that mutations in DNA. Teratogenic, obviously, and then carcinogenic. So again, they can cause cancers secondary to whatever you're trying to treat in the first place. So you gotta be careful with that. And then as a group, we'll talk about one specifically that causes really bad pulmonary fibrosis, but these can all lead to eventual pulmonary fibrosis if given for a long enough period of time. So you gotta be careful with that. Make sure you're monitoring things like PFTs for your patients over time. So the first group we have are the nitrogen mustards. These are based off of mustard gas originally. And so these include things like cyclophosphamide and ifosfamide. So you see like CPM or IFAX. These are the kind of the more common nitrogen mustards that we're going to use here. I would not put these on your hot dogs. These do not taste good. Tried it one time. Not great. But we use them to treat a lot of different solid tumors, a lot of hematologic cancers, very, very good at killing off cancer cells. But as I mentioned, there's a lot of toxicity that happens with that. So one of the big ones you see with cyclophosphamide and ifosfamide is it actually produces a metabolite called acrolein. Acrolein is very bad because it will bind to the bladder and can cause a hemorrhagic cystitis. That's kind of a unique side effect with these nitrogen mustards. And so what we'll actually do is we'll give a drug that helps to prevent that. And this is where our antidote comes in here called Mesna. So Mesna will be given along with cyclophosphamide in order to prevent that acrolein from binding to the bladder and causing hemorrhagic cystitis, right? So this is one of those cases where the patient did have red urine. That would be cause for concern because you were thinking that could be happening there. So you can also see some CNS toxicity. So this is a lot more with ifosfamide, but you have this encephalopathy. So you're monitoring for things like mental status changes over time as well to make sure you're not having any kind of drug toxicity from that standpoint. Again, renal toxicities are riskier, myelosuppression, alopecia. So again, not very these are very rough drugs, especially if you imagine, like, from a nausea vomiting standpoint, cyclophosphamide can be pretty rough from that. And we'll look at the immunogenicity just a little bit. The other thing you want to be careful of is make sure patients are vigorously hydrated when they're getting some of these drugs. So cyclophosphamide is a big one, where you want to make sure they're getting prehydration, hydration during the drug is being given, and the post-hydration, we'll call it. That makes sure that the kidneys are nice and tanked up and they have good urine flow. You want to make sure the patients do not get dehydrated, because otherwise they just hold on to the drug and that leads to further toxicity. You really want to make sure they get aggressively hydrated so they can flush all that stuff out. We have a few nitrosourea. So again, these are also alkylating agents, but they have a few different uses, as including carmustine and lomustine. This one's actually kind of interesting because they are particularly suited to treat brain cancers. We mentioned getting drugs into the CNS can be very difficult due to that blood-brain barrier, but things are more lipophilic, have an easier time crossing. And so this is where we have things like carmustine being used for things like brain cancer. This is actually kind of an interesting utilization here. We actually have this wafer that's been implanted with carmustine, and you can actually do this. If you were to, say, remove a brain tumor, you can actually then leave these little wafers in here to directly affect those kind of local cells that are still left behind. Because again, surgery can never get every single one of those cells, but you can leave the drug behind to try to get rid of them, have more of a local effect. It's kind of an interesting thing. And you go in later and take those out eventually. Just again, be aware that these are going to cause very severe myelosuppression, so you have to watch out for secondary infections. And sometimes what you'll see is you can actually have delays in the myelosuppression that can occur here. So again, anyone ever heard this term nadir? So it's basically kind of what's the lowest point you're going to hit, right? So again, after you hit, give them a chemotherapeutic drug, what's the lowest point they're going to hit, and when do they hit that? And this one's kind of interesting because you may think, okay, their counts look good. I gave them carmustine last week. They should be good to go, but you don't realize that it could be delayed 4 to 6 weeks before they really get really myelosuppressed, and that's when they're at most risk for having an infection. So you got to watch out for that. We also have our platinum analogs, and so these are going to be for patients that have the really good insurance. In the platinum base, I'm just kidding. No. They do have some platinum base in them, but these are used for all types of patients, insurance or not. And so this includes cisplatin, carboplatin, oxaliplatin. Basically, these are going to be binding very similar to the other alkylating agents we looked to, but you can see here how this can cause both interstrand bindings. So you imagine it's crosslinks that happen between different guanines here in different strands versus intrastrand bindings as well. So again, all these causes changes to the conformation of the DNA, prevents DNA polymerase from working on it, leads to that damage, leads to cell death eventually. And the platinum-based drugs are notorious for causing a lot of nephrotoxicity, so you have to hydrate really, really well for these drugs. Again, patients are getting liters and liters and liters of fluid. Typically these patients are able to tolerate it pretty well, but you need to hydrate very well for them. The other things you have to watch out for include Odo Toxicity. So again, you're doing things like hearing tests, make sure they're not having any kind of tinnitus or anything like that. Peripheral neuropathies, and you could see some hypersensitivity risk with this one. Again, these are another group that are very cause a lot of severe nausea and vomiting along with that. And then a couple other alkylating agents, we have dacarbazine and temozolomide. These get metabolized into this metabolite called MTIC that actually methylates guanine. So again, you can see how it's still working as an alkylating agent. Again, very similar mechanism, very similar toxicity profile to the other alkylating agents we've already kind of looked at. Then we have busulfan. This one's kind of interesting because this is very well known for causing a pulmonary fibrosis. So again, all of the alkylating agents can do this, but this one, if you're here, this is from my busulfan lung. This one's very well known for causing this. So it's kind of a unique thing with this one. Okay, so those are the kind of the primary agents we're using. It's kind of very non-specific. They affect healthy cells as well as cancer cells. We're going to look at a few things that can be a little bit more specific towards specific types of cancers here as we'll see. So we'll just look kind of a smattering of things. So we have some hormonal therapies. So when might hormonal therapies be useful? Well, at times when the hormones are the things that are actually helping to propagate the cancer. So you imagine like a breast cancer, estrogen is going to be really important. If you imagine things like prostate cancer, what's going to be really important there? Testosterone, and then also testosterone gets changed into dihydrotestosterone. DHT is really important as well. So we're going to see some things that can help to either block the effects of these hormones, or can potentially deplete the body of the hormones in the first place. So again, they have to be hormone-sensitive cancers, meaning they are very receptive to these hormones. So again, that's one of the things you're going to be testing for as well. Certain genes that might be expressed, things like that. But breast cancer, prostate cancer, endometrial cancer are probably the most common ones you're going to see there. And basically, they'll either antagonize the receptors or prevent that production of sex hormones, as I mentioned. We'll go into some of these a little bit more in detail when I talk about like kind of the female health. We already talked about the DHT and testosterone previously, so we won't have to go over that too much more. But then also corticosteroids are going to be another big component to a lot of chemo regimens. Not only because again, if you give corticosteroids, what does that do typically to the immune system? Suppresses it, right? Just like we saw, you can see secondary infections from this. You use this a lot for a lot of rheumatologic conditions. Same thing here. So this can be very useful for things like leukemias. And they also can be very useful for helping to treat chemo-induced nausea and vomiting. So you may see patients getting, let's say something like dexamethasone every day, which could be related back to like leukemia, or they could be getting it around the time they're getting chemo, which could be due to nausea and vomiting associated issues, right? So that could be another big thing you see there. Prednisone is a very common one. Dexamethasone, those are all good oral agents, very easy to come by. So, as I mentioned, when you have hormones coming around affecting these types of cancers, they have these hormone-responsive elements. They have those receptors within the nucleus that will help to promote things like cell replication and whatnot. So, we're going to find some drugs that will help to block those receptors or just, again, deplete the actual products from being made in the first place. So, you're going to find, again, as I mentioned, we'll have glucocorticoids that can be very useful for leukemia, as I mentioned already. They also have anti-estrogens. They're going to be useful for things like breast tissue, uterine tissue, ovaries, and then anti-androgens. These are going to be very useful for testicular and prostate cancer. So again, kind of makes sense where these are going to be working at based on the type of cancer you're dealing with, based on the whatever type of tissue is growing, what hormones are going to be most effective in treating that. So just some examples, we have like tamoxifen. So this is what we call an estrogen partial agonist, or some people call it a selective estrogen receptor modulator. That's where that term SERM comes from. We haven't mentioned this yet, have we? I don't believe so. So anyway, basically this is kind of interesting because you have drugs that can be an agonist for the estrogen receptor in some tissues, but then be an antagonist to other tissues, which can be very useful. So for instance, if you imagine if I were to deplete the activity of estrogen in a patient's body, what could happen? So what happens to a lady when she does not produce any of her own estrogen anymore? So they have a hysterectomy, or they start to get older. They have menopause, right? So they have symptoms of menopause. They have things like vaginal dryness. They have hot flashes. They have all these different things. This is one of the things you're going to run into where you can actually help to mitigate some of these side effects by having an antagonist at, say, wherever the cancer is, and having it be an agonist at other tissues. And we know that another big risk for, say, older women who have depletion of estrogen, what other tissue gets affected? Bones are a big one, right? So again, you see osteoporosis can be a big risk here. So we'll look at some of these and how they're going to be working. But basically, tamoxifen is one of the kind of primary ones we had for a while that was used for these estrogen-dependent breast tumors, essentially. And so you could also use it potentially as a for patients who are at high risk. If you have a high history of breast cancer, estrogen receptor dependent breast cancer in your history, in your family history, you can actually give this potentially to high-risk patients to help prevent it from occurring in the first place. That can be one thing you might see. Now, as you might imagine, the toxicity here, because this one's not very selective for acting as a antagonist, it kind of acts as an antagonist all over. You see hot flashes, potentially myelosuppression that can happen here, but also some pulmonary risk, or at least coagulation risk with things like DVTs and PEs. And then also because of his activities, it has been linked to endometrial cancer as well. The nice thing here, though, is it actually has positive effects on the bone because it will act as an agonist at the bone tissue, can help to kind of keep that working effectively. So again, we'll talk more about estrogen and progesterone when we get to the kind of the women's health section a little bit later on, but just be aware of how these drugs can be working for particularly these kind of hormone receptive cancers. Another one is raloxifene or Evista. This one is good because it has positive estrogen effects of the bone and the cardiovascular system, but it actually is an antagonist in the breast and the uterine tissue. Because again, if you have overactive more activity of the uterine tissue, you can end up seeing endometrial cancer develop from that. So we don't want that. So this is good to act as an antagonist in both these spots. And then you can see it a lot used in osteoporosis due to those positive estrogen effects on the bone. We have another one called fulvestrant. This one's kind of interesting because it actually downregulates estrogen receptors. And so again, this one's pure anti-estrogen. So it's going to be affecting the entire body because it's going to be given systemically. And so you can see that a lot of issues come about from that. A lot of the hot flashes, nausea and vomiting, vasodilation, headaches. So again, typically you start with things that are very selective for just that breast tissue. And then as maybe that is ineffective or the cancer kind of continues to grow, you may go on downstream to where you're going to get more side effect laden drugs, but again, it can be potentially more effective for actually treating that cancer. We have an Astragal and Letrozole. These are aromatase inhibitors. You guys remember that enzyme aromatase? We talked about that at all? This is really important when you're talking about steroid precursors and how you actually have or estrogen being formed. Aromatase is very important for that. So if you don't have aromatase activity, you can't form new estrogen essentially. And so you have decreased levels here, and so we can give this for some patients who may have estrogen receptor, sensitive breast cancer essentially. We're starting to see this replace tamoxifen in a lot of cases, so it's something you see more and more commonly. But again, very similar side effects: hot flashes, hair thinning, all of that, which you would see in someone who had menopause kind of naturally. And then exemestane, this one's kind of interesting because this is actually an irreversible aromatase inhibitor, so it's much more potent than you see with, like, say, letrozole we saw on the previous slide, because this is actually deplete estrogen levels by something like 90%. So very severe side effects from the menopausal symptoms, but very effective for treating those cancers and may be resistant to other drugs. And again, imagine like bone fractures can be one of the big things you worry about, because again, if you have that estrogen activity being depleted at the bone, a lot of osteoporosis develops there, risk for fractures that can be very, very debilitating for a lot of patients. Okay. Then on the androgen side, so I want to just ignore the guys, but we have a few that are actually going to be anti-androgens. So these include flutamide, nilutamide, and bicalutamide. These are good for prostate cancer, potentially for testicular cancer. And these actually help to block testosterone stimulation of those cancer cells by working as an antagonist at the actual tissue itself. We'll talk about leuprolide and goserelin in just a few minutes here. But as you might imagine, by depressing androgen activity, you're going to see kind of an overbalance over on the estrogen side. So that's where you can see gynecomastia develop with that one. So that's kind of one of the big side effects. And then these are kind of interesting. So we have leuprolide and goserelin. So these are actually going to be analogs of gonadotropin releasing hormones. You guys have covered things like the pituitary axis, the hypothalamic pituitary axis, where we talk about like gonadotropin releasing hormone, and that releases FH and LSH. Have you guys talked about that at all? Okay, we'll talk about that more when we get to the women's health section a little bit later on. But just know that gonadotropin releasing hormone is really important for stimulating release of FH and LSH, and that's what helps to do things like your the normal menstrual cycle, is what helps to stimulate sperm production. All these different things, really important for normal kind of androgen and estrogen activity. Anyway, what we can actually do is use an analog of GnRH, and this actually helps to depress release of these hormones, this LH and FSH, and basically by doing that, you're going to be decreasing the release of things like testosterone by suppressing that, which can be very useful if you're kind of failing other therapies. But again, as you might imagine, impotence can be an issue here because you're depressing testosterone levels pretty significantly, gynecomastia. Females, you can see estrogen depletion leading to hot flashes and all those menopausal symptoms. Okay, so it's kind of on again, just a brief kind of covering of some of the drugs you may see used for kind of a hormonal standpoint. Now we're going to talk about these biological response modifiers. Now these are going to be things that are going to be more specific. So the problem with things like alkylating agents and those other chemo drugs we talked about is they're very non-specific. They affect healthy cells along with these cancer cells. That leads to a lot of side effects. Myelosuppression leads to GI toxicity, all that good stuff. Now notice with the hormones, they're a little bit more selective, right? They're going to be affecting things like estrogen receptors in the breast tissue, or they're going to be affecting androgen production. These are even more specific than that, and so you're going to find that there's a group of proteins called these protein kinases. You guys remember we talked about different types of receptors before? We talked about G-coupled receptors. Remember the tyrosine receptors? Tyrosine kinases. Again, pull that stuff back out of the cobwebs. But basically, we have a lot of different protein kinases that we can produce, and they're very, very specific to different types of tissues. And so they're very important for signal transduction pathways where they stimulate things like cell growth, cell replication, and whatnot. So if I can inhibit this, then I can inhibit whatever production of those new cells are going to be. Lots of varieties here. We have things like insulin receptors. We have things like platelet-derived growth factors. Lots of different ones. But just note that certain cancer cells can actually produce very specific protein kinases, and if I can target that, then I can target just those cancerous cells. And that means we're going to have a lot less side effects associated with that, and potentially some really new novel therapies for very specific types of cancers. This is starting to become a big thing. You're starting to see a lot more of these drugs being produced nowadays because of the appeal of having very specific targets here. Again, just an example of how these cells are actually working. Remember, they have to have that signal molecule that will phosphorylate these. They come together, and then it can lead to cell response, whether it be cell growth or replication, whatever it happens to be. So, and just an example of how complicated these signaling pathways can be. Again, I'm not going to have you memorize any of this stuff. Just note that a lot of signal pathway communication happens through these tyrosine kinase receptors. So if I can block this, if I can keep that from activating, then I can prevent the cell from further replicating. So a good example of this would be something like imatinib or Gleevec. This is actually an oral medication. It was very effective for chronic myeloid leukemia, and this basically they had to express a certain mutation. So again, if I were to give it to a patient who had CML that did not have this specific mutation, the drug wouldn't work, wouldn't really be effective. But if they had this BCR-ABL mutation, then they would express this receptor, the drug would be very effective, and then you could basically cure that cancer essentially. So again, very specific, lack a lot of the side effects you're going to see with a lot of the non-specific drugs like cyclophosphamide or methotrexate. That kind of makes sense why they're so much more selective and why you limit those toxicities. So again, they see a little bit of nausea, vomiting, maybe some edema for the most part, not a lot of myelosuppression, much easier on your patient. Another example would be something like gefitinib. Notice how these tyrosine kinase receptors usually have an IB at the end of the name. That's kind of how I used to kind of recognize them. This one is good for non-small cell lung cancer, again, where if they're expressing a certain receptor here. So there's ERB, B1, or this HER1 protein, they have to express that. If they don't, then it's not really going to be that effective. So just, again, keep the concept in mind, specifically that these tyrosine kinase receptor antagonists are going to be things that are more specific. You have to have the receptor there. If it's not there, then the drug's not going to work. We also have a lot of antibodies, as I mentioned. So you guys remember the monoclonal antibody. So if you see MAB at the end of a drug, you know there's going to be a monoclonal antibody. You guys remember any problems with monoclonal antibodies? Any risks you see with giving those drugs? Yeah, so some risk for cancer in some cases, some risk for having immunosuppression, as we'll see here for a few of these. What's the other big risk? Yeah, allergic reactions, right? Because I'm injecting a foreign protein into the body, so allergic reactions are important. This is why you'll see that some of them have different nomenclature here, where you have like XI MAB. It means it's chimeric, which means it's basically has some human protein. A lot of times it also has like mouse protein or murine protein. It has UMAB, it usually means humanized, which the more human-based protein you can have, the less likely you are to see those allergic reactions, right? Rituximab is a big one. We see this used a lot for also other rheumatologic conditions as well, but this one is nice because it targets a CD20 antigen on B lymphocytes. So again, very specific for treating a specific type of cancer, and because it is so specific, it lacks a lot of side effects. And so you can see things like 90% of this non-Hodgkin's lymphoma express the CD20 antigen. So if I can target that, if I can give this drug in order to target those cells and inhibit that, then hopefully I can prevent those cells from being further activated. Okay. It also helps with things like complement-mediated lysis, apoptosis, and all that good stuff. So it's really, really effective for treating those cells that express CD20. These drugs are also nice because typically you don't have to give them very frequently. They're not oral medications, obviously, because it's a protein, so it has to be given as an injection. So this one's given as 4 weekly infusions. Obviously, I'd come back into the infusion center and get one every single week, and then potentially you could even extend that out for certain drugs. But obviously, kind of anaphylactic reactions are a risk here. You can see flu-like syndromes that happen here, spelled urticaria wrong, but things like bronchospasm, those are all things you can see due to that foreign protein being injected, right? Because again, this is a chimeric protein because you see that XI that's there. Very mild myelosuppression, but not nearly the same degrees you would see with something like cyclophosphamide. And then just another example is trastuzumab, Herceptin. This one's actually going to be affecting this human epidermal growth factor 2, this HER2 protein. And so by binding the antibody, binding up that receptor, you can end up having a very good suppression of replication of certain breast tumors. This is good for metastatic breast tumors that are actually expressing this HER2 oncogene. If it does not express that, it's not really going to be all that effective. So this is where some of these drugs actually have to do genetic testing beforehand to see if the drug even expresses it, and if it does, then you can utilize it. Otherwise, you have to go back to the drawing board and use something else. So again, I cut down a lot of these that usually we'll talk about just because, again, you're going to run into so many new ones that are coming out every single day. And in fact, I don't watch a lot of like TV typically, mostly a Netflix kind of household. But every time I go to my parents' house, they're watching like CNN or Fox or Food Network or whatever it happens to be. I always see tons of drug commercials. 90% of them I think are going to be these monoclonal antibodies for things like rheumatologic conditions, cancer, things like that. So if you go and watch TV, you'll see a lot of these commercials come up for these drugs because it is such a booming market. You can see these used in combination with other typical, more kind of typical chemotherapeutic drugs. So we give it something like a Taxol and doxorubicin. And again, given as weekly infusions typically, and again, those allergic reactions are things you want to watch out for when you give it. These are the things we'll typically give, like corticosteroids and say Benadryl beforehand to make sure they don't have that kind of reaction. And then if they do have a reaction, we have epinephrine ready to give at the bedside. Okay, and then so it's kind of just a brief, few examples of monoclonal antibodies used for cancer. We also have some immunotherapy. This is where we can actually utilize the body's own immune system to try to ramp it up to actually attack some of these cancerous cells. Because again, they kind of recognize that they're not normal cells and they want to get rid of them. Oftentimes, though, we just don't have the means to do that. So this is where this immunotherapy can be very useful here. So we have things like interferon. This will come up again when we talk about things like hepatitis, and we talk about, that's a primary thing we'll talk about a little bit later on. You have different varieties of interferon, but just note that this actually increases activity of things like natural killer cells. It will increase the phagocytic ability of macrophages, all in order to get rid of some of these cancer cells that the body still recognizes as foreign, but may not have been able to get rid of naturally. So these can be very useful. Not used as often as a lot of these other drugs we're talking about, but you may see it occasionally. So you can see for things like hairy cell leukemia, Kaposi's sarcoma. You know who gets Kaposi's sarcoma? Yeah, AIDS patients typically develop that. But we'll also see it being used for things like hepatitis C and B a little bit later on. Again, these are proteins. They have to be injected, but these tend to be a lot more immunogenic, mainly due to the fact that it's made from E. coli, so some of that proteins there can have a potential reaction. Nasty on the side effects standpoint. So you get a lot of flu-like symptoms associated with the infusion. You can also see things like depressed mental status. You can end up seeing very aggressive behavior. So I had I knew a person who had chronic hepatitis C that had to be on interferon therapy, and his wife was always like, you can tell when he's on it because he gets this like, he's very short temper, very, very aggressive whenever he's on it, because that drug is just, for whatever reason, affects the nervous, the CNS like that. So not a fun drug to be on. Again, probably would not use it in pregnant patients either, but just be aware of that. So there's other immunotherapy drugs that are out there, but I just want to give you just a brief smattering of them. Anywho, so looking at how we give chemo drugs. So I mentioned that a lot of these drugs are very specific to certain cell cycles, and that's why you need to be able to dose it appropriately so you get the highest percentage of those cells in that growth cycle as you can. I mentioned that count-dependent nature of a lot of these regimens where you have to give the patient time to recover, and this is where you look at things like monitoring their platelets and also their absolute neutrophil count, right? You guys looked at any lab stuff, looked at CBCs before? Usually you'll look at their white count, and then usually they're different. The differential will express the cell counts as percentages. Basically, you just multiply that percentage by the total white cell count, and they'll give you an ANC, or an absolute neutrophil count. If they are below a certain threshold for either of those two, then we don't want to give it, right? So you have to wait until the patient recovers, and then you can go ahead and get them give them a new round of chemotherapy. You're also going to be monitoring organ function for a lot of these patients. You're looking at things like renal function, looking at the urinalysis, looking at hepatic function. And to be very careful watching how the drugs are being dosed. As I mentioned previously, you saw that some of those are going to be based on their BSA, which is very good because it helps to eliminate a lot of the effect that weight can have. So you have very heavy or very light patients that can affect that, but BSA takes into account height, which is very useful there. Some of these things are age dependent, some of these are weight based, so you have to be very careful when you're looking at the dosing to make sure that none of this stuff gets screwed up, right? As far as safety and handling goes, so again, you have to be careful handling chemotherapy because, again, it's not only carcinogenic potentially to your patient, but it also can be to you as well. So hopefully you guys will not be in a case where you have to handle a lot of chemotherapy, but you could be. You could be very close to these patients, dealing with them. You have to think even their secretions that come out of them after receiving chemotherapy can be considered hazardous, right? So you have to be careful with that. Think about diapers, think about their urine catheters, urine bags, things like that can all have potential traces of chemotherapy, which can be dangerous to patients. So especially patients who may be prone to getting pregnant, right? So a lot of nurses have to be very careful with this because it could be of childbearing potential, maybe want to get pregnant, you have to be careful with that. So this is why it's very important to make sure we have a proper PPE. Anyone know what PPE stands for? Personal protective equipment, right? So gloves, gowns, shoe covers, because again, anything gets stained could be a problem here. If you have a risk of anything being aerosolized, you want to make sure you have a mask and eye protection to prevent any hazardous materials from getting in contact with the mucous membranes. And then, as mentioned, the excreta should be considered hazardous as well. Typically, we'll consider it for some period of time. Usually, it's 24 or 48 hours after they've finished receiving chemo. We'll still consider that to be hazardous, and we have to take care of it and dispose of it in a certain manner. So, you have to be careful with that, especially blood, diapers, etc. We had one patient, so if you imagine some of these chemo regimens, you're getting, say, something like methotrexate for 5 days straight, right? 24-hour infusion. So you imagine being a teenager, you're locked up at the hospital getting 5 days worth of methotrexate, you're on this IV pole, you're going to go a little stir crazy in your room, right? I'm sure anyone would. So you want to get up and walk around. So I mean, one patient who was doing that was back in the hospital very soon after opening, and his kid was just wandering around the hospital, just taking his little IV pole, his methotrexate infusing. I was walking by the pharmacy, and he must have got snagged on something because the line came out and started having methotrexate going everywhere. So one of our technicians came out, and he was like, "Oh my gosh, it's, fluid going everywhere," and patient's freaked out, doesn't know what to do. He's just like, so he goes and starts like trying to, had no PPE on whatsoever, and so again, now that's an exposure. And so, obviously, he'd had no untoward effects, but it's one of those things you have to be very careful. You have to look at things like spill protocols and all of that to make sure that you have to protect the patient, but also the people that are working at the hospital as well, right? So again, everything turned out fine with that patient, but again, just be very careful with that. And then we had a policy where it's like, okay, well, lock the patients up in the room practically to prevent them from having any issues, or they just stay on the unit, whatever happens to be. As far as supportive care goes, some things we can give, some adjuvant therapy to help recover our patients include things like hematologic care, where we know we're going to depress their immune system. Let's give them drugs to help stimulate that. And so we can have things like colony stimulating factors. So if you see CSF here, again, imagine your kind of common cell lines here. Things like erythropoietin, what does that do? Stimulates red blood cell production, right? So sometimes we'll give these patients erythropoietin if they're anemic, right? Sometimes we'll give them granulocyte macrophage colony stimulating factors to help produce things like eosinophils and basophils if they're neutropenic from that standpoint. So again, these are drugs we can give. We have recombinant forms of these that your body naturally produces that we can give to the patient to help kind of stimulate them. So this is very useful because, one, if we see these patients can have very depressed immune system, we want to prevent them from getting infections. So if we can help to stimulate that recovery a little bit faster, we will do that, which can be very nice. The other big thing you have to watch out for, if you have a neutropenic patient, how you give medications to them. So one of the things you see, especially with you receiving chemotherapy, is that you're hitting the GI tract as well, right? You're hitting those rapidly dividing cells. That tissue now becomes more friable. Anyone heard of that term friable before? What does that mean? It's kind of brittle, it's kind of easy to break through. And so it's one of those things where if you have a neutropenic patient, you cannot give any rectally administered medications, you cannot use any kind of rectal thermometers or anything like that. Why do you think that is? If I break that tissue, what can go into the bloodstream now? Bacteria, right? And they're neutropenic. So it's one of those things where only certain routes of administration can be given to patients who are neutropenic. And rectal is one of those big no-nos, right? So that's one of the things to consider. Another thing, if you have a patient who's in the hospital on the unit, they need to receive or they cannot receive fresh flowers, right? Because that's a lot of bacteria that are on it. Or they cannot receive fruit where you would eat, like, they can't just bite into an apple. They need something that has actually a peel on it, right? So that way they can get rid of those bacteria because they are so at risk for developing infection. So little things you may not think about necessarily unless you work with these patients a lot, but at least kind of give you an idea about it now. And just keep in mind that they can be corrected with time, but in some cases, patients, we want to recover them a little bit faster. We'll give these colony stimulating factors to do that. So either erythropoietin, we'll give them actual GM, CSF, they'll help to replenish their white cell line as well. From a GI standpoint, nausea and vomiting is super, super common, probably one of those common adverse effects you're going to see with administration of chemotherapy. We talked about antiemetics already, but just when you go to the quiz, we're going to you'll see that is going to come back up. So remember, we have lots of different varieties of antiemetics we have available. We have our serotonin antagonists, we have antimuscarinics, we have our substance P antagonists. Go back and review that because, again, this is something that's very integral to their chemo regimen to make sure they're not going to be having a ton of nausea and vomiting. Not only can they get dehydrated, but also who likes to throw up? No, it's miserable. So we don't want our patients to have to do that, right? Keep in mind the mucositis, it's very, very painful. Can prevent them from eating and drinking. So this is why we also worry about infections. Need really good oral hygiene. So where we do things like salt rinses, or there's also an anti-infective called chlorhexidine that we'll use just in the mouth. So you ever see like chlorhexidine swabs, we'll do that and make sure they try to keep their mouth nice and clean. Because again, people's mouths are pretty gross for the most part. So we can clean that out, prevent that infection from forming there. Here's just an example of a metagenic potential guideline. So every hospital or infusion center usually has the guidelines on this to kind of give you an idea of what type of antiemetic regimen they're going to need. So for instance, if they're getting a really high risk emetogenic drug, something with a greater than 90% frequency of vomiting, things like, say high dose cisplatin or cyclophosphamide or the doxorubicin. If you're getting certain doses of these drugs, they're very likely to cause nausea and vomiting. You get a very intensive regimen of antiemetics versus something that may be just a moderate risk, or something might be a very low risk. And so that will change whether they just get a dose of Zofran, or if they're getting dexamethasone, Zofran, they're getting aprepitant, they're getting lorazepam. Anyone ever heard of lorazepam before? Ativan? We'll talk about that in the neuro section a little bit later, but some of these patients, they have such a bad experience with this nausea and vomiting. They know that they're going to get that chemo, that they're going to throw up. They get this anticipatory nausea and vomiting that happens there. So sometimes we'll even give them things like benzodiazepines to kind of calm them down a little bit. And so we'll talk about that more when we get to the neuro section later, but just keep in mind that there's lots of different regimens we can try to help prevent these patients from throwing up. As far as the skin goes, for alopecia, really nothing we can do for that, unfortunately. Very distressing for a lot of these patients, but no good pharmacotherapy, so nothing there. And then with the extravasation, you have to be very careful. Some of the big ones we worry about, as I mentioned previously, are the Anthro Cyclins, vinca alkaloids, the taxanes. This can have very severe tissue damage, so just be aware there's different regimens for each drug. Some require hot, some require cold, some require certain things that will help to break down subcutaneous tissue and allow it to absorb better. So that's a drug called hyaluronidase here, or Hylenex, that actually helps to break down that connective tissue in the subdermal layer and will allow it to be absorbed more easily and help to mitigate some of that damage being done there. Okay, so that's our whirlwind tour of chemotherapy. Any questions I can answer for you based on that? Yes, ma'am.
On the interferon A's, would we be writing like for alpha 2A? Like how would we write that?
You'd probably have interferon alpha 2A, and then you would have usually like a brand name associated with that. That helps to kind of make sure you can differentiate between the different products.
But not the lysine 23 part?
Probably not. They probably wouldn't write that. Yeah. Yes, ma'am.
In that table, the second to last slide, it says it has two sides. Which is the, because I know cisplatin is the chemo drug on that side, but how is that organized in?
It was just a full list. It was just the second column there was just a continuation.
Oh, got it. Okay, so it's not like antiemetics are separated from.
Nope.
Okay.
No, it was just all the chemo drugs were on there. Just had to list it out somehow. Right. So questions I might ask are going to be things like, okay, a patient is receiving methotrexate for their ALL. What would be an antidote to help prevent renal dysfunction from receiving methotrexate? So you'd say, okay, well, I know it's methotrexate. I know it can precipitate out in the urine. I know we alkalize the urine. In order to prevent that, I know we give sodium bicarbonate, right? That would be the antidote for that particular issue with methotrexate. You would not give folinic acid for that because that doesn't really do anything for the kidneys, right? Folinic acid is going to be more useful for helping to rescue those kind of healthy cells after they receive methotrexate.
So you're going to give a specific problem and the antidote for that particular problem?
That could just be an example, right? So I'm just trying to think of things off the top of my head of what it could be. Some of it will be basic, like what's the mechanism of this drug, or which drug has this particular mechanism. Could be things like, which patient is. Trying to think of any other good examples. But it's not going to be based on which one would you use to treat, ALL. Which one would you use to treat Kaposi's sarcoma? Because again, that's more specific than what our really purposes are here. And again, even if you're not that interested in treating chemo or treating cancer patients, you're going to run into this all the time, right? You're going to have patients who are on these drugs that are coming in to see you. If you're working in the acute care, you're working in the ER, wherever you happen to be working, you need to at least be aware of them. So that way, if you know your patient's been getting methotrexate and cisplatin and all this other stuff for their cancer, and they come in with the fever to the ER, guess what? Okay, well, I know they're neutropenic because they've been receiving those drugs. We need to treat this as a certain way versus, and it actually can influence things like which antibiotics you're going to give those patients. It can influence a lot of things, right? So just be aware that you're going to run into this stuff whether you like it or not. As I said, I hate chemotherapy, but every time I go to Nemours, guess what? We got a lot of patients with cancer, and guess what? They need their drugs too. So we have to go through and we have to make sure that we're dosing the drugs appropriately, we're choosing the right drugs, we have the right supportive care, because it's a long process, and it's very important that we get it right. So, any other questions I can answer for you? Yes, ma'am.
Should we find primary source articles for the quiz?
No, you can just use our information that we have been presented in the slides, and go back to Chemo Man. He will help you with that. He will guide your hand in answering the questions. So turn that in electronically by next week, so by the start of class on Friday. I'm doing the assignments a little bit differently this time around, so there's going to be 3 assignments that will be due along with the test. Those are going to be prescription writing assignments. So basically, I'm going to give you some scenarios. You're going to be writing a prescription for a certain drug. Your job is to actually write out that prescription. I'll post some of that stuff up as we get closer to when it's going to be due. But it'll be pretty easy, but it just gets you into the process of writing prescriptions, right? Because it's one of those things that a lot of the students don't get a lot of experience with until they're actually out in rotations, and by then it's kind of like, well, it's nice if you knew that beforehand, right? Anything else I can help you guys with? All right, well, hopefully you like the morning classes. Good way to start your Friday. Thank goodness it's not at 2 o'clock on a Friday, right? Okay, I'll see you guys next week.